The case we're going to discuss today is of a 70-year-old woman who presents with symptomatic disease, is found on CT scans to have a lesion in her right kidney, as well as both adrenal glands and a thyroid nodule. Undergoes a right radical nephrectomy with pathology indicating a clear cell renal cell carcinoma, a resection of one adrenal lesion, RFA ablation of the other, and is placed on sunitinib therapy as initial management of her cancer. She's on that therapy for approximately 7 months and then has progression of disease. And so we enter in at that point to discuss what would be the most appropriate second-line therapy in this patient with relatively small volume, although intermediate risk, clear cell renal cell cancer. And the patient elected to receive second-line therapy. The patient was placed on lenvatinib and everolimus. This particular case is somewhat unique in the setting that it is an intermediate risk patient just based upon risk factor analysis using whether the Hang criteria or the Motzer MSKCC criteria, and that the patient has had the presentation within 1 year of diagnosis of metastatic disease. So this is a presentation synchronously of metastatic disease, but the amount of disease outside of the kidney is small. The doctors that were treating her elected to proceed with what amounted to metastectomy with radiofrequency ablation of one lesion as well as surgical resection of the other, but did not attempt surgical resection of the thyroid nodule. Some of us would have considered that to render the patient NED, and at that point we would have just monitored the patient with proactive surveillance CT scans every 3 months. However, given that the patient did have one area of disease, that being the nodule in the thyroid, the doctors elected to start the patient on sunitinib therapy. Now, when one looks at how the patient responded to sunitinib therapy, and we have no information about the patient's general tolerability of the medication or the dosing, the patient had some disease control, obviously, that lasted 7 months, but ultimately there was progression. When we look at the length of time the patient had benefit, i.e. 7 months, we would say that that falls within the range of what one would consider standard for an intermediate risk RCC patient, based upon the years of data that we've collected of the use of sunitinib as a frontline therapy. I would not say that this patient was exquisitely sensitive to VEGF therapy, just that they had the average response to VEGF inhibitor therapy. Also, looking at the sites of metastases, the presence of a solitary thyroid nodule, although not rare in kidney cancer, is certainly not the usual presentation, where most patients will have multiple pulmonary nodules, lymph node metastases, prior to the development of rarer target organ involvement, such as the thyroid. When one looks at the presentation of this patient and the identifiable characteristics that one has available to them at the time of diagnosis, this patient clearly falls within the intermediate risk category, whether one applies the more modern Hang criteria, which is based on the targeted therapy error, or one uses one of the other criteria, such as the Memorial Sloan Kettering criteria. And that's predominantly based upon the synchronous presentation of disease. The patient, without a doubt, has one risk factor. We also want to gauge whether or not the patient is tolerating the disease burden well. This patient is already symptomatic with fatigue, weight loss, despite having relatively small volume of disease. So that certainly weighs in and is certainly affecting the patient's performance status, which is not ideal.